Now let's understand and revisit the basics. We know that in an HRCT chest, we get thin sections which are basically less than 1.5 mm. They are contiguous. This is a contiguous imaging, and there's high special frequency. So, as you must remember when you're writing down a CT chest for your patient, you must write, it is mandatory that you write that you need a supine inspiratory film, an expiratory film, as well as a prone scan. We always get supine inspiratory film, but why is it important to get an expiratory and prone scan? Because prone imaging would help you to differentiate between true pathology from dependent changes. Look at these two CT cuts. Okay, in the left one, you can see there is diffuse ground glassing at the basis on the supine image. Now, when this patient was put in prone imaging, as you can, if you can appreciate, these shadows have disappeared. So these could be dependent changes and it might not be the true pathology. So it helps you to rule out the dependent changes. Similarly, in this axial cut, if you can observe, there's ground glassing, some interlobular septal thickening as well in both the bases, and this uh, remains in the prone images as well. So, this goes to show that this is most likely a true pathology and it is not changed. Sometimes it might reduce in prone imaging, but does not essentially unchanged, which goes to show that there is a pathology. So the dependent changes which are there and they basically get removed in prone imaging. Now, what is the importance of expiratory imaging? It helps you to detect air trapping. It is useful in small airway diseases. Uh, Air trapping is basically the areas of low attenuation that persist on expiration, the dark areas. We'll look at these as we go ahead. And they can be accompanied by bronchial wall thickening and plugging in some cases. Now, when we image the pulmonary interstitium, we look at it includes the axial, which is around the bronchi, the interlobular between the lobules, and intralobular within the lobule zones. So between lobules, within the lobules, around the bronchi, right? And again, something very important, you must know the smallest functional unit of the lung structure, which is visible on imaging, which is the secondary pulmonary lobule, which is supplied by a lobular bronchiole and a pulmonary artery in the center, divides into three terminal bronchioles and then further into 20 to 39 acinus. It is important. Again, there is a centrilobular artery in the center with a terminal bronchiole, and at the periphery, you have your lymphatics and veins within the interlobular septa. Why it is important for us again to understand the very basic of secondary pulmonary lobule? Because in the centrilobular area, it is usually the site of diseases that enter the lung through the airways, like your hypersensitive pneumonitis, respiratory bronchiolitis, or centrilobular emphysema. And in the perilymphatic area, which is the site over here wherein you have a lymphatics and veins, is the site where the diseases are located in the lymphatics, like your sarcoid, lymphangitic carcinomatosis. So if you understand this basic structure, you can easily identify and understand the underlying pathology. Now, after the basic technical aspects and the importance, I mean, the basic functional structure that is your secondary pulmonary lobule, we have the opacities. So, what are linear opacities? Linear opacity is a linear structure that represents an interlobular septal thickening. It's interlobular and is oriented perpendicularly to the pleural surface. Okay, and reticular opacity comprises of linear opacities that intersect one another at various angles and form a reticulated net-like pattern. So these are the findings that we see on HRCT chest. We'll look at them as we go ahead. The next opacity that we look at is the ground glass opacity, which refers to an area of lung parenchyma showing increased attenuation that does not obscure the underlying vessels and bronchi. The difference between a ground glass and consolidation is this. The uh, the increased attenuation or the opacity that obscures the underlying vessels and bronchi is your consolidation, and the one through which you can see the vessels and bronchi is your ground glass opacity. Now, always remember having a structured approach to interpretation of HRCT is important because it helps you to understand the presentation as well as the underlying pathology and delineate your differentials and be able to diagnose. So, firstly, it is the dominant HR pattern, which can be reticular. There is predominance of reticulations. It can be predominantly nodular. There can be high attenuation, which is your white, the high dense, high attenuation, the white, the ground glassing, the consolidation. and low attenuation, which is your cysts and emphysema. So the dominant pattern is the first thing that you first try to identify in your CT. Then you look at where within the secondary lobule is the pattern. Is it centrilobular? Is it within the center of the secondary lobule? Is it perilymphatic around the fissures or the subpleural region, or is it randomly distributed in the throughout the lung fields? Then after the dominant pattern and the location within the secondary pulmonary lobule, you look at where is the predominance, whether it is upper versus lower zone or central versus peripheral predominance. And then, of course, additional findings like pleural fluid, lymphadenopathy, traction bronchiectasis. As again, with a structured approach, these help you to identify the underlying disease. So let's look at the first dominant pattern, which is reticular shadows, the reticular opacities. Now, reticulations uh, can have basically septal thickening. Now, this was a case, if you can see, there is smooth septal thickening. And there's also presence of bilateral pleural effusion. So, this was actually a case of pulmonary edema, and the patient had smooth septal thickening. Similarly, look at this focal area wherein you can see nodular septal thickening. So, this was a case of lymphangitic carcinomatosis. And so, reticulations can have septal thickening, which can be smooth or nodular. And the causes of smooth uh, are pulmonary edema, central venous pulmonary obstruction, ARDS, pulmonary alveolar proteinosis, lymphangitic carcinomatosis, pulmonary hemorrhage, lymphoproliferative disorders, infections like pneumocystis jirovecii, and diffuse alveolar septal amyloidosis. Then nodular lymphangitic carcinomatosis can have both smooth as well as nodular septal thickening. Nodular is also seen in sarcoid, lymphocytic interstitial pneumonia, diffuse alveolar septal amyloidosis, and your lymphoproliferative disorders, your lymphomas, leukemias. So again, septal thickening. This is CT showing you smooth. This is a CT showing you nodular, and this is your irregular. That is a third variant, which is an irregular septal thickening. Now, this is usually seen in cases of fibrosis and like fibrotic hypersensitivity pneumonitis, chronic diseases, sarcoidosis, your silicosis, coal workers pneumoconiosis, asbestosis, and even in your UIP. Now, once you've understood the reticulations, the presence of these linear or reticular opacities, along with associated features, can help you identify the underlying associated radiological pattern and the associated disease. For example, a patient with linear and reticular opacities, along with traction bronchiectasis and honeycombing, would suggest a UIP pattern and would be a UIP IPF, right? Similarly, associated with ground glass opacity would be NSIP. Air trapping would be seen in fibrotic HP, and triple density pattern, which is very characteristic of HP. Nodular thickening or ground glassing suggests the lymphatic spread and can be seen in various diseases like sarcoid, lymphangitic carcinomatosis, pulmonary edema. Now, the other reticular pattern apart from septal thickening is your honeycombing, which is presence of small cystic spaces lined by bronchial epithelium and with thickened walls composed of dense fibrous tissue. And it is typically a pattern of usual seen in UIP. Now, after reticulation, we look at the nodular pattern, the dominant nodular pattern, which we've discussed previously as well. So your nodules can be present in perilymphatic distribution, centrilobular distribution, as well as random distribution. Now look at this axial CT cut, and this was a case of hypersensitive pneumonitis, and ill-defined centrilobular nodules are ground glass nodules are seen. This is not only seen in HP, but also in cases of respiratory bronchiolitis in smokers and various infectious airway diseases. Now, tree in bud is nothing but your nodular shadows, which are basically, linked with your Y-shaped or V-shaped linear shadows, which represents basically your dilated, impacted centrilobular bronchioles, which is the tree in bud. Now, tree in bud is seen commonly in infections like TB. This was a case if you can appreciate, there's a good tree in bud appearance here in an active TB patient. There are various causes of tree in bud pattern. Now, perilymphatic distribution is very characteristic of sarcoid. So whenever you are suspecting sarcoid and you have a presentation, always look around the subpleural region and the fissures. Always look at the nodule presentation, because this is very specific for sarcoid around the fissures in the subpleural spaces, and also in the upper lobe, and perihalar predominance is very typical for sarcoid. A random distribution of nodules is generally seen in because of hematogenous spread in cases of metastasis, miliary TB, miliary fungal infections, sarcoid. So when you have a patient of multiple nodules, first look whether there is any pleural nodules present or not. If the pleural nodules are present, look at the predominant pattern. Where are the nodules? Whether if they are subpleural, septal, and peribronchovascular, this means this is a perilymphatic distribution, as seen in cases of sarcoid, silicosis, and lymphangitic carcinomatosis. Then, if you have you have no predominance and they're diffuse, that means it's random distribution, and this is seen in cases of metastasis, miliary infection, like that in TB and fungal infections. If no pleural nodules, then it's a centrilobular distribution within the center of your secondary pulmonary lobule, and seen in cases like hypersensitive pneumonitis, infection, bronchoalveolar carcinoma, respiratory bronchiolitis. So then the third dominant HR pattern that we look at is the low attenuation, which is your cysts and emphysema, the black portion, right? So it is basically the attenuation because of or the air-filled lesions, the decreased attenuation, like in honeycombing, traction bronchiectasis, lung cysts, emphysema. This is showing centrilobular emphysema. So then the fourth dominant pattern that we see is the high attenuation, which is your ground glass opacities and consolidation. There are various acute and chronic causes of ground glass opacities. And again, when there is lung obesity through which there is without any obscuration basically of your underlying vessels and bronchi, it is your ground glassing. And once your vessels and bronchi are obscured, it is your consolidation. Now, a dark bronchus sign is when there is ground glassing and the air-filled bronchi, they appear usually dark against the surrounding lung tissue, which is that is abnormally opaque. So this is called the dark bronchus sign, and it basically it highlights the underlying lung pathology. An air bronchogram is something which we see commonly in the consolidated area, and it is seen both in HRCT as well as on the chest X-rays. Now, in high attenuation, there is something called the mosaic attenuation. So mosaic attenuation basically helps you to differentiate between the affected and the non-affected areas. It can be seen in asthma, constrictive bronchiolitis, HP, and pulmonary embolism. So, to appreciate mosaic attenuation, when you look at this inspiratory film, you look at this picture and you might think that there is, some ground glassing, or maybe there is some uh, air trapping present here. But then this mosaic pattern, the underlying cause, whether this is an affected area or an unaffected area, you need an expiratory film. And you look at the expiratory film, if you see these white portions, this is basically your normal lung, and the air trapping has basically become prominent on your expiratory film. So this basically shows and tells you that there is presence of air trapping, which is appreciated on an expiratory film. On an inspiratory film, you can see some mosaic pattern, mosaic attenuation. So this is another presentation of your high attenuation uh, pattern. And it is, of course, a representation, air trapping is a representation of small airway disease. Then the next one is your crazy paving. Now, crazy paving is nothing but your ground glass opacity with superimposed septal thickening. It was thought that it is very specific for pulmonary alveolar proteinosis, but there are various conditions in which you can have a crazy paving pattern. Now, high attenuation also has consolidation. It can be like these were two cases which had patchy, non-segmental, subpleural, and peripheral distribution of consolidation, and various differentials were there. This was a case of cryptogenic organizing pneumonia. Even in chronic eosinophilic pneumonia, you can have similar presentation, but patient would have fever, may or may not have peripheral eosinophilia. BAL would show more than 25% eosinophils. So high attenuation has ground glassing and consolidation. Now we'll look at the ground glass opacities, which is increased attenuation that does not obscure the underlying vessels and bronchi. Now, presence of ground glass basically depends upon the onset of your disease. Now, acute ground glassing less than 2 weeks is seen in cases of infections, cardiogenic pulmonary edema, hemorrhage, diffuse alveolar hemorrhage, chemical pneumonitis, even COVID-19. Subacute, which is 2 to 4 weeks in case of organizing pneumonia, drug-induced lung injury. Chronic, more than 4 weeks, is in more of fibrotic chronic conditions, fibrotic ILD, NSIP, HP, and some neoplasms. Now, let's look at the differential diagnosis of diffuse ground glass opacities. Now, diffuse alveolar damage. Diffuse alveolar damage can have various causes: pulmonary infection, aspiration, systemic causes, sepsis, pancreatitis, burns, surgery, and even idiopathic, acute interstitial pneumonia, or even TRALI. So, these patients usually present with a rapid onset. They're very hypoxemic. Most of them meet the clinical criteria for ARDS. As you can see, there is diffuse ground glass opacities, there is bilateral basal consolidation, dependent basal predominance in the consolidation. So, diffuse alveolar damage would present like this. It's a very rapid onset. Very quickly, these patients deteriorate. So, you require very prompt treatment. Then, cardiogenic pulmonary edema would be patchy, lobular, parahilar, bilateral, ground glassing. And as you can see in this, there is also presence of pleural effusion. Cardiogenic pulmonary edema can also have smooth interstitial thickening, smooth subpleural interstitial or fissure thickening as well. Again, in the coronal cut also, you can appreciate diffuse ground glass and there's smooth septal thickening. In non-cardiogenic pulmonary edema, the presentation is basically depends upon the underlying etiology and causes of ARDS, infections, trauma, TRALI. And as you can see in this, there is ground glassing, there is basal consolidation, there is also presence of some fusion. Diffuse alveolar hemorrhage. Now, diffuse alveolar hemorrhage would have multifocal areas of ground glassing. It's generally central and dependent areas. Patient would have recurrent hemoptysis, would present with cough, dyspnea, can have iron deficiency, anemia. And in the later stages, you can even have interlobular septal thickening. Acute interstitial pneumonia. So most of these causes of diffuse ground glassing, these are all acute causes. They all present very acutely, very rapid onset of symptoms. They often land up in ICU. They have respiratory failure. Most of them also require ventilatory support. So in this case also, as you can see, there is bilateral ground glass opacities. There is like acute interstitial pneumonia can have sparing of individual lobules. Then generally in the lower zones, it is symmetrical. And in the later stages, it can have architectural distortion. Now, acute exacerbation of ILD. Now, this is the diagnosis which you actually first make on the presentation and the how the patient is. A patient with ILD would already have features of IPF on his CT and on his CT, and you cannot really differentiate whether it is an infection or just exacerbation. Of course, there would be patchy ground glass opacities in exacerbation. So once you've ruled out infection, then you treat the patient as an exacerbation of ILD. That you must rule it out clinically and based on the investigations that you require for that patient. Now, hypersensitivity pneumonitis can have patchy and diffuse ground glass opacities. It can also have interlobular septal thickening, areas of decreased attenuation, that is air trapping, which is triple density sign, which is very characteristic of fibrotic HP. If you can appreciate here, there is air trapping, there is normal lung parenchyma, and there is ground glass alternating areas, which is the three density sign, which is very typical for your fibrotic HP. Then atypical pneumonia. This was a case of pneumocystis cerevisiae. On an X-ray, you would see diffuse haze. Ground glassing is a finding of CT scan. So, in a case of atypical pneumonia, this was pneumocystis cerevisiae. There was bilateral diffuse ground glassing. These patients can also have consolidation with septal thickening. They can also have cystic spaces. As you can see here, these are different presentations, but the main finding was diffuse ground glassing bilaterally. Similarly, in cytomegalovirus pneumonitis also, you would have diffuse ground glassing, but the main feature in both of these is diffuse ground glassing. You have to rule out depending upon the patient. When you have an immunocompromised host, you need to send appropriate respiratory samples, ET secretions, do a BAL when possible, send the secretions for both the infections, and in CMV, you can also send the blood samples and rule it out. Then this was actually a case of H1N1 pneumonia, atypical viral pneumonia. So you would have, you can have central lobular nodules, you can have lobular diffuse distribution of ground glass opacities. Again, an atypical viral pneumonia. This was a case of COVID actually, but again, there can be presence of ground glass opacities in lobular or diffuse distribution. There can be segmental consolidation with areas of air trapping and even presence of centrilobular nodules. Now, acute eosinophilic pneumonia, this was a patient with fever of less than 5 days. BAL had more than 25% eosinophils, absence of parasitic and other infections. So bilateral patchy ground glass, they would have interlobular septal thickening, giving you a crazy paving sort of a pattern, crazy paving pattern. You know, a lot of these patients have peripheral eosinophilia, but a lot of them don't have peripheral eosinophilia also. Then organizing pneumonia would also be bilateral patchy distribution with areas of sparing, airspace, ground glass consolidation. There could be mixed appearance. You have atoll sign, reverse halo sign. There could also be presence of parenchymal bands in cases of organizing pneumonia. Then DIP is a smoking related disease. There is clubbing in 50% of the cases, marked reduction in diffusing capacity, and you would have basal, peripheral, subpleural ground glass opacities, occasional interlobular septal thickening, small cystic spaces, maybe also thin-walled cysts may be seen in areas of ground glassing in cases of DIP. Now, these are mostly acute causes of ground glassing. Let's look at the chronic causes. Now, we know that fibrotic ILD, you see honeycombing, reticular shadows, and traction bronchiectasis. So, non-specific interstitial pneumonia, NSIP, in this CT, as you can see, there is diffuse ground glassing. Now, this can also have a fibrotic presentation where it can have traction bronchiectasis, diffuse ground glassing with areas of traction bronchiectasis as well as bronchiectasis, but there is usually no honeycombing. Pulmonary alveolar proteinosis, we've already talked about ground glassing with superimposed patchy interlobular septal thickening, giving the crazy paving pattern. Then LIP is, we are going to be talking about this today. So it's a slow onset, fifth decade disease. In adults, it is associated with autoimmune disorders. And the characteristic features include ground glass opacities, perivascular cysts, as well as the reticular pattern. RBILD would have extensive centrilobular nodules. It would have patchy ground glassing, bronchial wall thickening, minor centrilobular emphysema, predominantly upper lobe. It is a smoking related disease, mild cough dyspnea. PFT may have normal or mixed pattern. Now, there are certain associated features on imaging which help you to identify associated conditions, like there can be bronchial wall thickening, bronchiectasis, air trapping, and cysts. Now, how do you approach a patient with ground glass opacities? Firstly, detailed history. You can never forget clinicals. I think throughout these series, we've heard distinguished radiologists talk about how important it is, how important the history is for them. So exposure to specific antigens, if you're suspecting HP, connective tissue disease features, whether there is an infective etiology, whether the patient had fever or not, exposure to toxic fumes, any history of aspiration, any ongoing anticoagulation, what is the immune status of the patient, this will help you delineate the underlying cause and accordingly proceed. Then distribution also helps you to identify certain conditions like focal in case of hemorrhage, infection, infarct, diffuse and diffuse alveolar hemorrhage, edema, upper zones, HP, sarcoid, silicosis, lower zones can be NSIP, UIP, collagen diseases, tree in bud in case of infection, fibrosis, and even in cavities and infections and infarction. Then there are certain CT signs also that help you to identify certain conditions like crazy paving, halo sign, reverse halo sign, presence of specifically centrilobular nodules with GGOs or cysts. So as per your history, clinical presentation of the patient, you accordingly proceed to investigate. If you are suspecting a CTD ILD, or you're suspecting specifically a vasculitis related underlying condition, then you specifically send your RA factor, anti CCP, ANA profile, ANCA, CRP. If you suspecting a pulmonary renal syndrome, then you send for an anti-GBM antibodies. In cases of infective etiology, you would send specific respiratory samples, whether it is your sputum, secretions, throat swabs, nasal swabs for multiplex PCRs. For a diffuse alveolar hemorrhage patient, if you do a bronch, your ball would have hemosiderin-laden macrophages, HP panel in the suspected case. Then, in an immunocompromised host, you want to send PCP, CMV, PCR from the respiratory sample. So, wherever it is clinically indicated, depending upon the clinical presentation, you send specific investigations to rule out the underlying cause. So, to sum up, the diagnostic approach to interstitial lung disease, step one is when you have a diffuse lung disease, clinical information. Never forget your clinics. Presence of fever, any history of smoking, exposures, hemoptysis, on anticoagulation, distribution of abnormalities, whether it is in the upper lobe, middle lobe, lower, axial or peripheral, symmetric or asymmetric. Then pattern of abnormality, nodules, ground glass opacity, consolidation, septal thickening, cysts, air trapping, honeycombing, emphysema. What is the pattern? Then associated findings. And after this, you accordingly proceed for investigations that we talked about, which is your step four. So you have to always be very precise, always have a systematic approach, always have a stepwise approach to identify the underlying diagnosis. So to conclude, pattern recognition on HRCT forms the foundation for accurate diagnosis in diffuse lung diseases. Linear opacities, often reflecting septal thickening, can be smooth, nodular, or irregular. Reticular opacities result from intersecting linear opacities forming a net-like pattern, and they're essential for diagnosis. Nodular pattern requires classification based on the location, that is your centrilobular, perilymphatic, or random. Ground glass opacities must be analyzed in context to the onset, acute, subacute, or chronic. It helps you to differentiate the underlying etiology. Distribution of abnormalities on CT, whether upper, lower, axial, peripheral, or central, provides a strong diagnostic clue and can help you identify suggest certain specific diseases such as HP or asbestos. Associated CT features such as septal thickening, tree bud, fibrosis, or cavitation further help you to refine differential diagnosis. And prone CT plays a critical role in differentiating true posterior lung disease from gravity dependent changes. A systemic stepwise approach, gathering relevant clinical history, exposure data, analyzing the distribution patterns, recognizing key imaging features, and integrating lab results maximizes your diagnostic accuracy. Timely and accurate HRCT pattern directly impacts the patient management by guiding appropriate further investigations. You're not over or under investigating your patient, as well as it minimizes unnecessary tests and enables a targeted therapy and improves outcomes. Thank you. These were my references. I have to mention here that this clinical radiological series by Ashu Seth Bhalla ma'am and Manisha Jana was published by JP Publications. We've used this book extensively during this series as well. It provides a lot of information, and it has great insights into the interstitial lung disease imaging. Thank you.